It is my pleasure. I've gotten to know Mr. Wipond over the last few months. Most of you may know this, but if you've never planned a conference or an event, guess what? It takes months and months and months and months. And some of you were on the planning committee. So it was several months ago. I was made aware of Mr. Wipond. He spoke at a NARPA conference, and I was blown away by his presentation. I reached out to Mr. Stone and get his thoughts, and he agreed that Mr. Wipond would be a fabulous speaker for this conference if we could get him. And he was, when I reached out, kind enough to say yes. I don't want to tell Rob's whole story, but he is from out of town. He's from the Great White North. He could tell you a little bit more about that if he'd like. But over the last couple months, and then just recently with our events, Rob's written on the back table a really important book. It's a bit of a wake-up call for those of you that haven't been following some of the issues in our field, community behavioral health generally. I think it really will maybe shock you if you haven't been following the news, and you may say to yourself, you know, is that true? Is that real? Let me couple things. I'd ask you to read the next chapter and the next chapter and the next chapter, because these are not isolated instances that Mr. Wipond talks about in the book. And something that maybe not everybody picks up on is the extensive references that Mr. Wipond's made available that support everything he says in the book, and that's available online. And there's a link to that, I think, in the book. So that's important that you know that he really does cite his sources and tracks that, because once you start reading the book, you'll realize, wow, these are pretty strong statements, you know, so it's important to cite your work. So let me do a brief intro. I don't want to steal any more of his time. We'll be going until 11:55. Similar to our previous speaker, we'll try to break, if it's okay, Mr. Wipond, give us 10-15 minutes, because this is a talkative group, both online and in the room. So if you're comfortable giving some time at the end for questions, I have no doubt. And you can see with the microphone, I can easily get around to you, and you can ask your question. So Rob Wipond is a freelance journalist who writes frequently on the interfaces between psychiatry, civil rights, policing, surveillance and privacy, and social change. His articles have been nominated for 17 magazine and journalism awards for writing in medicine, science and technology, business, and law. He has taught journalism and creative nonfiction at the University of Victoria and Royal Roads University, and he also works and volunteers with nonprofit groups that do neighborhood community building. He's the author of the book, Your Consent is Not Required: The Rise in Psychiatric Detentions, Forced Treatment, and Abusive Guardianships, available through BenBella, and again, at a good discount here at the conference. It's available on Amazon as well as here. Please join me in welcoming Mr. Rob Wipond to the stage.
All right. Okay, let's do a little sound check here. I can tell that's all right. I know that I don't have any notes, so I have to look at my own slides now and again. So what happens if I turn like this? Oh, that's still okay. You can hear me all right? Good. So I'll try not to do that too often, but sometimes I'll actually want to read along with you with the slides. So what happened there? Oh, there we go. What's going on? Oh, wrong way. Figured it out. All right. So today's talk, both 911 and 988, help and horror on everyone's speed dial. And it's really, the book is about the expanding uses of civil mental health laws. So I only touch on the forensic system, which is the criminal psychiatric system, here and there where it's overlaps with the civil mental health system. Although, you know, in reality, the bleeding together of those two systems is becoming a really big issue. So moving ahead, that might be the next book or something. So I want to talk first about the dominant public narrative that's out there about forced treatment. And that is this sort of story. It's from the New York Times, kind of summarized in this way. The number of public psychiatric beds available has plunged to 11 per 100,000 people from 360 per 100,000 in the 1950s. And as a result, homelessness and imprisonment of people with mental disabilities is skyrocketed, and this as a really common story. In fact, when I told people what I was working on, often, even if they knew nothing else about the mental health system, they would usually start telling me this story. Go, well, here's what I know. And I'd be like, yeah, I've heard that story. So yeah. Along with this, part of this story is that due to bed shortages and strict interpretations of dangerousness criteria in mental health laws, it's almost impossible in most states to involuntarily detain anyone. This is, psychiatrist Aoife Lertori of Treatment Advocacy Center being interviewed on 60 Minutes. We kiddingly say you have to be either trying to kill your psychiatrist or try to kill yourself in front of your psychiatrist in order to get hospitalized. And then stated often or just implied within this dominant narrative that's out there in the news media and everywhere else among legislators is that the science is clear, forced treatment creates people who feel and are better, and they have better lives, and they're grateful for this experience. So this is a narrative that I found in all of these, and this is just a sampling of the news media. I found this narrative and so exact that almost those exact same numbers are cited, and usually, well, not usually, in every single one of these. I only included it here if they were specifically quoting Aoife Lertori or the Treatment Advocacy Center or both. So really it's Treatment Advocacy Center that is behind this narrative. They've been extraordinarily effective at getting it into news media from left, right, middle, everywhere in between across America and Canada. So now we're going to fact check it, the dominant narrative. That's pretty much my whole book does. And we're going to do a quick overview of it today. Everybody's favorite pastime today, fact checking. And we're going to look at these sort of elements: people's experiences, the legal criteria, the rates of mental illness, bed numbers, detention numbers, what's really going on. And that's what my book tries to explore the most of. Again, I'll look at the scientific evidence and some suggestions about what we truly need. Yeah. So what is involuntary psychiatric treatment? I like to start here because it's the personal element, and there's a lot of personal stories in my book. But today I'm going to focus mainly on kind of the factual data that underscores it. But really, almost every chapter of the book includes people's experiences of what it's like to be involuntarily treated. And there's not a lot, but there's definitely some research into that as well. And what we find in the research is that perceived coercion is key. So you can be nominally involuntary. I can bring you into the hospital and say, hey, I'm really sorry. We just feel compelled to do this. You're clearly seem to be in distress of some kind. We're going to hold you, but hey, let's talk it through. Like, have you ever taken a medication before? Would you like to try one? How about this one? And you try it, and then we'll see. People are treated respectfully. There's a mutually respectful sense of relationship. And I call that kind of a nominally involuntary experience. And it kind of distorts all of the research, because if you have those kind of people mixed in with the people who say, no, I've tried that medication, I don't like it. No, I really don't like your attitude. I don't feel respect for you. I don't feel I'm being respected. And they start to put up resistance. Everything plays out very differently. So, and those are the people that I'm focusing on in the book mostly. So and the research bears this out, that this is a key issue. And so when they separate out that group of people, and this is what involuntary actually means. When you start to resist, these are the kinds of things that very commonly play out. So along the way, you've got a police apprehension that may have brought you to the hospital to begin with. There's security guards. Your belongings are taken. You can be forcibly stripped. You're in a locked or semi-locked institution. There's monitoring, surveillance. There can be threats, intimidation. Often you might get an injection of a tranquilizing or sedating drug if you've put up resistance to taking oral medications. And then depending on your situation, this can go on for days or weeks, and then even into months and years in an extended setting, a different kind. And more often today, that's happening in communities. So there's a bit cut off at the bottom, but force is usually experienced by people as these are the kinds of things they reported to me. And again, you can see this in the research: humiliating, traumatizing, brutal, like being put in a chemical straitjacket, one of the worst experiences of my life. And, I heard this kind of testimony again and again. So let's go through these sort of facts now. Hardly anyone meets the criteria for detention. Well, the step one legal criterion, it's important to remind ourselves, is that you are suspected of having a mental disorder or have a mental disorder. None of these laws apply unless that's in the cards here. And that's why, you know, people can go skydiving and they don't get arrested for dangerousness. But as soon as they get a label of a mental disorder on them and they're skydiving a lot, this can actually come up in a hearing. You know, I've heard those kinds of really typical things that people would ordinarily do that are somewhat dangerous become really highly considered, shall we say, among judges and tribunals and psychiatrists when they're discussing your dangerousness. And I'll talk about that in a second. But sticking with this mental disorder label first. So as of 2022, the National Institute of Mental Health says 50% of children will have a mental disorder before the age of 18 in America today. So that's 50% of the population. Some of the latest, you immediately go, well, what's the lifetime prevalence rate for everybody then? Well, a very recent study that was published in the Journal of the American Medical Association, Network Open, said that 85% of adults will have 2 or more psychiatric disorders before the age of 45. That was done in New Zealand, not in America, but in any case, it's just indicative of where we're going overall with these sort of the notion of who has a mental disorder and what a mental disorder is. It's been expanded hugely such that, you know, if you're one of the people who is never going to meet the clinical criteria for a mental disorder, you're a rare person in our society today. So where does that leave us? It's important to keep these numbers in mind because often it gets forgotten, right? So then we see a study that says something like 37% to 40% of jail inmates have a mental disorder. Oh my God, that's such a huge number. And you know, among the homeless, it's 25 to 70% have a mental disorder. Yeah, but then let's remind ourselves, hey, the lifetime prevalence in adults is somewhere around 50, 60, 70, 85%. So in fact, it looks like people in jail and people who are unhoused are mentally healthier than the average population. So, yeah, thank you for laughing, because to me, it is just ludicrous. It's absurd. Like, I'm not trying to make a point here other than I think all of these numbers are totally absurd. And it's important to understand this underscores all scientific research in this field right now, is that the notion of what a mental disorder is all over the map. It doesn't depend which disorder you're talking about. The criteria gets so hazy and so vague along the way. I think Joanna Moncrief just showed, suddenly 15% of the population seems to have bipolar now, right? Which was just, 10 years ago considered a very serious and severe mental illness. Now practically anybody seems to be getting it. So yeah, this is underscoring everything. Along with this, again, fact checking, hardly anyone meets the criteria. So the main criteria we have in virtually every jurisdiction in America and Canada, and really in most Western countries that utilize criteria of these kind, the risk of danger or harm to self and the risk of danger or harm to others are the most common. Risk of grave disabilities practically everywhere now. So the idea that you may or may not be able to take care of yourself in some basic needs. But the new one that's been breaking, it's already installed in many jurisdictions. It's right here in Ohio right now, though it's before your Senate. It was thrown back to committee recently, but it's still in process, is this notion of risk of mental or physical deterioration. This is the broadest of the broad, where really the way it's worded, and this is common across jurisdictions, it's like a movement that's going, and really, again, it's a treatment advocacy center and National Alliance for Mental Illness that are behind a lot of this lobbying to get these criteria passed. And this notion is, it's, as the wording says, if you may be, notice risk of is all of this. It's never even needed to be proven, but you're at risk of possible mental or physical deterioration that may lead to you someday potentially meeting one of the other criteria. So now essentially it's a very Orwellian or Kafkaesque criterion, which says you can be committed now if in future you might be committable. So that's where we're at with these laws. That's how broad they've become. And I say it's extremely dangerous that this is happening, that this is even being discussed and taken seriously. And that's kind of what my book is about, is already showing, even back at danger, we've got really broad use of these laws occurring, let alone when we get to something like mental or physical deterioration, where really anybody can be committed. So, and there's a quote from Michael Perlin, one of America's top legal scholars. I highly recommend The Hidden Prejudice, Mental Disability on Trial. It's his sort of summary work. It's still virtually unreadable because it's 2/3 pages of footnotes on every page, but it's amazing his summary of really all of the legal research in this area. And he says the definition of the word dangerous is vague, amorphous, and inspires I know it when I see it attitude. And that's how I saw, I attended hearings, I talked to people, I talked to, tribunal members and judges. And, this is just the reality. This is how these decisions are made. It's like, yeah, I'm getting the sense that you're dangerous, I'm going to lock you up. And you'll see psychiatrists using that terminology as well in their writings often, that they don't want to be beholden to the law. And I cite some examples of that in my book where they blatantly write, like, we should not be constrained by these, by lawyers and judges and what they believe. So here are some fact-checking on the impossible to detain anyone. Some numbers from Canada that I managed to get: Alberta doubling, British Columbia doubling, Ontario doubling. The data was incomplete in a lot of places, and many provinces didn't respond at all. I'm using this term that David Cohen, the UCLA researcher, who I'm going to cite in a moment, that did a similar study in America. He calls them data black holes, that we're finding those everywhere. So the data basically right down at the very basic thing: how many people are being forcibly treated? We really don't know. Even these numbers are highly questionable because it's unclear often which people are being included, because sometimes people are brought in for just a day or a day or two, and they're just put back out again, and they may not be recorded. So for example, in Maryland, when I was looking into this, they were in the middle of a public process of, let's expand forced treatment. We aren't detaining enough people. So I said to the government, okay, how many are you detaining now? They had no idea. It was a big rigmarole. Eventually it was something like 72 people in the whole state for the whole year. And I'm like, are you sure? That doesn't seem right to me. Oh, okay, yeah. And they're going back and forth. Oh, that's only for state hospitals. State hospitals hardly house anybody who's under civil mental health law anymore in Maryland. Okay, where are they? Oh yeah, you're going to have to talk to the Office of Public Defender. So the government didn't even know. Department of Mental Health didn't know. Legislators didn't know. Their official response to me as a news media representative is, we don't know how many people are being involuntarily detained under civil mental health laws in Maryland, even though we're in the middle of a political process of trying to expand it. And so then the Office of Public Defender said the number is 4,000 people per year. Okay, from 72 to 4,000. But then we looked at those numbers together. I said, it doesn't look like it's going to be including this other group of people who are brought in before they get a hearing, and they can be kept for a certain period of time before they even get a hearing. And they said, yeah, we're right. You're right. We're trying to get those numbers. And within a year, they had those numbers, and it was closer to 9,000. So here we are, the numbers are going up by orders of magnitude just when somebody starts digging. And up till now, nobody had ever dug in Maryland, and that's the home of Treatment Advocacy Center. So they obviously weren't going after the numbers. So overall, that was 150,000 people annually in the United States, in Canada, and that's about 400 per 100,000 people. And there were about 5 to 15% were repeat patients. So it does happen, you have a certain percentage that may be incarcerated twice in a year, and then a much smaller percentage that it could be 5, 6, 7, 8 times. But overall, that wasn't a huge influence on the overall numbers. And that will be also, this is a study, it's cut off there, but from G. Lee and David Cohen at UCLA, looked at what sort of data they could find across America already, sort of pre-existing. And here they found similar trends as we're seeing in Canada. Florida doubling, Colorado doubling, California, child detentions tripled. So it overall only went up 30%, but I just found this out recently because I was working on an op-ed about California. And we found examples where only 1 in 10 of incarcerated patients were being actually reported to the state. So this is when a guardianship pilot study, they hired a consultant to actually go out to the healthcare institutions in San Francisco and go, how many people are you really holding? Is the number you're reporting to the state accurate? And guess what? They found out that no, it was 10 times as big. So San Francisco immediately went from the lowest incarceration, psychiatric incarceration in the state, to the highest, one of the highest I've seen anywhere. So they also found in 22 states where they could get continuous data, per capita detentions increased 3 times faster than population growth. So these numbers have been going up for a couple of decades quite consistently and steadily. And in 2014, in half of the country, it was 600,000 people. By extrapolation, say 1.2 million. And they found about 357 detentions per 100,000. So again, similar to Canada, a little bit lower, and similar repeat patient number. So, what is this telling us? So it's telling us that everything in the dominant narrative around the numbers is completely wrong. For 2 decades, there's been more and more and more people already being incarcerated under civil mental health laws in the country. So how is that happening? Because we have no beds, right? There's this total drastic shortage of beds. Where is everybody being incarcerated? So somebody else looked at that, because if you actually pay attention, if you know anything about community mental health services, you know that state hospitals do not tell the entire story. So it's actually kind of ludicrous that this narrative has been able to succeed out there. And I can't help but think it's because a lot of mental health organizations are not simply going, well, wait a minute, you shouldn't even bother with this, because we know that in our state or in our county or wherever it is, people are being detained outside of state hospitals. And so we got to talk about that, but somehow they're not. And I think that's one of the problems, is that mental health organizations of different kinds are often in a conflict of interest, because they know this narrative gets more funding and gets more government support if you go with the dominant narrative, which is that there are hardly any beds. So anyway, the National Association of State Mental Health Program Directors, the people who actually run these systems, knew it was a lie. And so they quietly did their own study, which they barely publicized at all. It was done back in 2017. And this was the purpose of the study as described by the authors. The shortage of psychiatric inpatient beds has become a major national issue, but most analyses fail to include a comprehensive depiction of the total inpatient and other 24-hour mental health residential treatment capacity across the nation. So they set out to actually find out how many beds there were. And so here they start at the most simple level that really anybody should be able to tell the news media, and somehow never does. And that is that inpatient beds are not only state hospitals, but county and private psychiatric hospitals, the residential treatment centers. There's dedicated beds for serious mental illness in nursing homes and psychiatric wards in Department of Defense and Veterans Administration, and psychiatric wards in general hospitals. And they ended up with a number that was 10 times higher than that 11 beds. It was closer to 114 beds per 100,000 people across America. But that wasn't the whole story. So they kind of hinted at the rest. And then I looked at some other data to kind of pull this together, which you can see in the book. So you add in all these other beds where people are being kept, right? Because they're often funneled out of these institutions where they're being, for short terms, incarcerated and then shuttled elsewhere. And they're in assisted living, supportive housing, group homes, addiction treatment centers, and elsewhere. You start adding all these up and you get a number that's 60 times higher. So I want to just say this is very rough. Don't go around saying that Rob Wipond says there are 3 times as many beds as there were in the 1950s, but roughly that is what I'm saying. So when I looked at I added all this up, you could go as low as in the 1950s that we're at about 190 to 250 beds per 100,000. And it's as high as 600 beds per 100,000 today. But I will say that needs much more rigorous study. There are kind of these overlaps. It depends what you define as a bed and so on and so forth. But really, I just highlighted to say, all of this shows the dominant narrative that is out there is way, way, way off the mark. That we know for sure, and that we need to have a meaningful discussion and probably right down to the county level in every state in the country to go, okay, how many beds do we have of all of these different kinds? Where are people staying? Where are they being forcibly treated, and where are they being coerced? Because we know in an average group home, I talk about this in my book, in an average group home, people are often under constant coercion, even if they're not under an assisted outpatient treatment order. They're just so monitored that it's like they do anything wrong, or if they go off their medication, often the person that runs the group home will just send them up to the hospital for the day, get them thrown back on their meds and brought back again. We'll talk about that more this afternoon in our community coercion discussion. So where are all these people? Who are all these people? This is what really the book is about. So one of the biggest funnels is 911. people are doing these wellness check calls on everybody. Anyone could do it. You could do it on me right now. I could do it on you. Police are basically duty pound to respond. There was an example in New York City here. They had 170,000 of these kind of calls in 1 year. And, you know, it's coming from all of these varied types of people, teachers, business owners, neighbors, housing operators. 86% of those calls resulted in somebody being psychiatrically hospitalized. They didn't track whether that was voluntary or not, but you can presume that since it was often somebody else calling about someone else, that it may not have been free. So here's another big funnel. I was surprised to discover that the National Suicide Prevention Lifeline, already prior to morphing and transitioning into 988, was one of the biggest funnels into psychiatric detentions, forced psychiatric detentions in America today. So I only found that out by doing it took me a year and a half of freedom of information requests to finally get some data out of SAMHSA. National Suicide Prevention Lifeline, Vibrant, Emotional Health would not give me anything. They were absolutely refusing. SAMHSA did not want to give me anything. I had to go back and forth with them over a really long time to get some data. So they have about 190 call centers around America. I think it's probably higher already as 988 expands. It's run by Vibrant, and they advertise all the time as being anonymous and confidential. And most of these centers, and the main advertising for 988 now and for the NSPL earlier, did not disclose this. As you can see in that ad, it's not prominently disclosed anywhere that they may trace calls. And so what I did find is they do have a very clear policy and practice of tracing calls. What they don't do it themselves. They contact 911. They run people through a simple screening tool, which I'll talk about in a second. What they do is they contact 911 and they can ping the geolocation feature in your mobile device and find out where you are fairly accurately. They can do it other methods, but that's the most common method today. This is baked into your phone. You can't turn it off. It was used to be a helpful thing for people in emergency situations under 911, but it's being increasingly used for all these other purposes. In fact, there's some cases going on in America right now where police were using the same feature to track suspects without warrants. And, just because this tool is so readily available to them at all times. And it's just very easy to I'll just ping that person and go find them and track them down. And there's no outcome tracking. So we have a lot of data black holes here. What happens to the people whose calls get traced when they get hospitalized against their will? So what do we know about that process? It's a risk assessment. It's about imminent risk, not imminent death. So they'll often tell legislators, as they did during the 988 hearings, we only do this with people that are right in the act of killing themselves. But if you look at the data, you find that seems to be a very small percentage of the overall number of people. So what they're actually doing is a risk assessment of a person. We think you might take your own life in the next few hours, the next few days. Even in their policy, they say up to a week. So it gets very hazy. And indeed, that's what all the research says. This is very hazy at the best of times, that even after 50 years of research, the average, even an expert opinion cannot predict suicide with anything better than random chance. This is Madeline Gould, who's on the one of the committees for the National Suicide Prevention Lifeline and 988. In one of her own studies, she said empirical foundation for warning signs of imminent suicide risk is lacking, and the concept is fraught with problems such as lack of clarity and imprecision. And of course, this is being done by both trained experts and volunteers, whoever's answering the phone on any given day at one of these centers. So they often just use a very rudimentary screening tool. What are you thinking about suicide? Have you thought about how you might do it? That sort of thing. And a study of 4 NSPL centers found that the rate at which they were tracing these calls varied from about 0.5% of calls to up to 8.5% of calls. So all over the map, like, why were these centers making the decisions they were making? And I talked with people that work at them routinely, said, yeah, that's it. Like, our numbers go up and down based on how recently we had a training to try to bring them down or try to bring them up, or whichever direction we were going. So where does that ultimately lead? NSPL had, this is the data I got from their internal data from a survey they did. So out of about 1 million calls, 21,000 callers were subjected to this kind of police and ambulance intervention. That's about 1 in 50. That's a number now that's being circulated publicly. They're kind of admitting to it. At estimated 44,000 callers total. So 44,000 people per year in the United States are being incarcerated in psychiatric hospitals as a result of their calling a confidential and anonymous line. So a certain percentage involve caller collaboration. But what that is essentially, you know, at a certain point they go, look, we're going to either send the police around by pinging your device, or you can give us your address right now and we'll send the police around and they'll know that you agreed to this. And I would think that most people today in America, knowing how the dangers of wellness checks, I would probably give my own address out right away under that degree of threat, because I'd think it's better if the police think that I'm complying right off the bat rather than that I'm going to put up a fight. So another thing to keep in mind is actually only suicidal people are only 20% of calls to the NSPL. So the number of suicidal callers would seem to be 1 in 10 rather than that, rather than 1 in 50. So that's an important thing. That's just my own analysis based on what you're seeing right there. So I don't know that that's the case, but I'm assuming that most of these ambulance call and police interventions are coming with suicidal callers, and that's representative of the number of suicidal callers there actually are. But also mobile mental health crisis teams were sent to another 108,000 callers. And there's no indication in the survey they did whether those were coercive or how coercive they might have been. So those numbers can start to go through the roof. Plus the fact that these call centers also had another 8 million calls in total, because their calls through the NSPL, the 800 number, were only a portion of the calls that these community-based centers are actually fielding. They're fielding far more calls through their own lines that are based in their communities, and they weren't asked about those. So presuming they have the same policy, the number of people that are being incarcerated through this system could be much, much, much higher. Just some developments more recently that I found. This was some data I found again through another Freedom of Information request. So the Lived Experience Committee at the National Suicide Line has been protesting this for years. And there's been infighting at the NSPL, which was never reported to legislators during the 980 hearings, really. And it's certainly not at this scale. Here's a quote from the minutes of their meetings where the Lived Experience Committee members were saying things like that the dangers of brutalization, violence, and criminalization, especially for populations that have been historically marginalized or victimized by law enforcement and mental health systems, is a real problem. And so they were fighting against us and saying, we got to do this less. We got maybe even stop it. And nevertheless, while this was happening, Vibrant and SAMHSA were lobbying the government for direct control over NG 911 surveillance power. So that's next generation 911 that'll be able to, because right now they have problems with people in apartment buildings. So this is going to be a 3-dimensional axis down to 3 meters. That's what's coming out in 911. And Vibrant is trying to get direct control over that. They don't want to bother even having to call 911 anymore. They want to just get everybody's default geolocation the moment you contact them. And then they'll have that available at any time. If they decide to send out police and ambulance themselves, they'll have a direct call to that. So they're lobbying for that power, even as this sort of controversy is going on. And so since 988 implementation calls are up about 50%. And reportedly, according to Vibrant, when I asked them, they would not give me the data again, because I said, I'd like to see that. So you're releasing all this new data on 988. I'd like to see the caller intervention numbers. And they said, well, it's holding at 2%, meaning that it's going up dramatically, the numbers of people it's affecting, but they wouldn't give me the data. So I'm suspicious that it's worse, because they've had to bring on a ton of new people to just do this randomly. And I would assume that a lot of callers are just operating from the basis of fear, nervousness, and inexperience, of saying, okay, let's default to calling in an intervention. So the 988 legislation is promising, however, because it does suggest that we need more data gathering and reporting to government. So that will hopefully happen. There's a multi-stakeholder panel that's been created to review the request to have direct surveillance powers. And something else I want to highlight here that's relevant is that states are authorized under that legislation to use a tax or a levy, a fee to fund 988 in the same way they kind of use a levy right now to fund 911. So that in the end could have a number of effects. So the 988 number is probably going to start drawing callers away from local community lines and play, you know, in Ohio. Understand you have lots of independent call centers here that are not already part of the National Suicide Prevention Lifeline or 988. They're gonna start losing callers because, of course, people will just naturally think of, oh, 988, it's easier to remember, start calling them. And at the same time, they're not going to get any of that 988 funding. So there was lobbying to prevent independent call centers from getting that money. Vibrant and other centers were saying, no, let's not give them. And the government agreed to go along with that. And so now there's going to be enormous pressure on everybody to join 988. And then they'll have to, if they aren't already utilizing call tracing, they'll have to implement it because it's part of the 988 policy. So that's the 988 story. Going to move on to the rest. I'm just going to check my time here. How are we doing? Pretty good. So the other thing I looked at then is where else are people being funneled into detentions? So one of the most common I found was family and domestic conflicts and disputes. So this is interesting because, of course, there's a strange assumption that just seems to operate out there that if I start saying, oh, you know, my child is this, it can even be my adult child, right? And they're so troubled and they absolutely need this forced treatment. We need to expand the laws, or I need to get them incarcerated. There's some strange assumption that seems to operate that that person is well-intentioned, whoever they are. And that, of course, they have only the best interests of their child at heart, even if their child is resistant to being forcibly treated. And I think that's an assumption we got to get rid of. I mean, I'm sure it's true in lots of cases, but it's also true, not true. And I found many examples of that, where there was a blatant abuser in the family, and that abuser was utilizing mental health law powers to control their own child in some way, right through adulthood. And so we need to talk about that kind of more when we're discussing the whole issue of family conflicts and disputes and how they're playing into the laws and the use of mental health forced treatment. Schools skyrocketing. Anywhere we can see numbers, they're getting kids who are distressed or disruptive in class taken up to psychiatric hospitals against their will. Parents get cut out of the loop. There's been some amazing reporting on this going on at the Tampa Bay Times down in Florida, where they've tracked the numbers a lot better. They can show that the rates of child detention is going up, but wherever we've seen data, I showed you data from California earlier, the numbers of children being detained in psychiatric hospitals is going up and up and up everywhere that we have that data. So long-term care in nursing homes is another common place. They're using antipsychotics for behavior control against FDA recommendations, right? There's the black box warnings against using them in patients with dementia. They're often being used there, and mental health laws will get invoked if there's any resistance from either the patient or the family. These are all chapters in my book, essentially, where I go into this in great detail. So active duty soldiers and veterans, this is much more common than I realized. There's a certain level, about 26% of veterans, for example, get 26% of people in veterans hospitals are being detained against their will under civil mental health laws. But I also found that there were sort of other tools and leverage that were used because it's the military and people are just taking orders. And this is what the officers were telling me is that you can just threaten these orders, people with being decommissioned from the military, losing their pensions and other things to coerce them, or just give them an order. Say, it's your commanding officer, report to behavioral health. Workplaces. So there's all this training going on in mental health first aid and workplaces, psychological first aid. People are being trained. If you look at those trainings, within 3 to 4 steps, you're usually being told to call 911 if you have any concerns at all and get people locked up. I found this happening in lots of cases. In one of them that I talk about in the book, a guy was just having a fight with his human resources manager when he got laid off, hung up the phone. There's a dispute of what actually got said, but a tactical SWAT team was at his house within minutes and dragged him up to the psychiatric hospital. He was kicked out again the next day, but not before he went through a very terrorizing experience and was heavily drugged against his will, knocked out. In the morning, they're like, oh, you don't need to be here. And they sent him home again, but he's been forever after traumatized. And that's an example of what can happen and is happening in workplaces right now. Also, I found that conflict resolution processes, so more traditionally, the conflict resolution processes did not utilize a medicalized model, but now they're increasingly using it. So somebody gets a diagnosis labeled, oh, you're experiencing, if there's an untouchable person within the organization, somebody who's a higher versus lower on the hierarchy of power within a corporation or government, often the person at the lower rung is being told, you've got a disorder of some kind, you should be in treatment, and that can escalate into blatant force, even though already in a workplace setting, you're under a certain degree of coercion already. And then licensure threats. This was huge. So some of you probably know this as social workers, as clinicians, nurses, doctors, you all have employee sort of physician health programs. They're called for physicians. So some sort of program that is there for your own well-being. And they've become a very, very aggressive on the mental health front. So I talked with a number of physicians who've been put through this kind of experience where at threat of the loss of their license. So they were never involuntarily treated. Technically, they didn't come up in those numbers that we saw earlier. But there's this huge swath of people who are being put into coercive treatment under threat of losing their licenses. And it's an interesting story in and of itself. Sometimes it's medication, sometimes it's some kind of residential treatment program they have to participate in. It looks like there's maybe a lot of fraud involved. There's enormous amounts of money being made off of these physicians. They're charged often $50,000, $60,000, $70,000 for a few-month residency program for substance abuse treatment or something related. Banks, airports, tax authorities, government agencies, I found examples of all of them utilizing these laws routinely to get rid of complainers and protesters. As somebody becomes more belligerent or upset, and maybe there was something going on with that person, right? In some cases, I had that question myself when I'm interviewing the person, oh, okay. But often it's just a mix of, okay, maybe they did have some sort of, distressing things going on in their life that were amping up how they responded to the situation, or they just weren't a very articulate person. Maybe they were wrong in the thing they were complaining about and the other people knew, so they just thought of them, well, you're crazy because I've already explained to you that your complaint isn't justified, blah, blah, blah. In any case, these things were being utilized. As a bank manager said to me too, hey, like people do commit sometimes. If they're trying to take out a lot of money, we immediately start asking questions about, well, is there extortion going on? Or are there two names on that bank account where the other person should be consulted? And so people coming in, maybe they're high at the time. And so we want to prevent. So of course, a bank has a legitimate reason to be concerned, but it's also a concern that they have this extraordinary power they can use where they can essentially get you incarcerated virtually immediately simply for showing up and making a request that they don't think is wise. And guardianships are another huge and expanding area. And so interestingly, again, these people would not appear in the numbers. So everybody who's under a guardianship can be forcibly put in a hospital by their guardian, but they're not recorded as an involuntary patient. They'd be recorded as a voluntary patient because the guardian voluntarily put them under that. So, and we're just, again, that's a huge data black hole. The federal government in the US has just hopefully been passing some legislation trying to require states to gather more data on how many people are being put under guardianships and what's happening to them. And then underneath all this, it's important, or over top of it all, it's important to understand that there are these major cultural drivers that are influencing it all. And we do have data that shows this, and I saw it routinely too, just in attitudes. But, poverty is a common reason why you'll more likely end up involuntarily treated. If you're a person of color, if you're homosexual, if you've got other, at sort of outside the box behaviors of any kind, essentially, as our culture is currently defining quote unquote normal, you're more likely to be a target of this kind of treatment. And there's a lot of studies that sort of back that up. And of course, and that's compounded by the fact that you may also be, because you might be falling into one of these groups as somebody who's poor or somebody who's trans or something, you may be more likely to be feeling suicidal, you may be more likely to be experiencing distress, or you may be more likely in a family conflict where your family doesn't support your decisions and things like that. And so that itself makes you more likely to get swept into the mental health system. But now, because of the prejudices on the other side, you're doubly so. So this was a huge area that I was not prepared for myself, was kind of looking into the dollars of this and where this leads. So these are all numbers related to America. We've got, it's about $1,000 to $1,500 a patient day. The base rate from CMS is about 840 right now, 860, and that's just the base rate. It kind of goes up depending on location of the hospital and all that. And this is what I found some studies sort of verifying those numbers. And now, notably, that's 10 to 30 times the daily rate that's paid for prison inmates. And American Hospital Association data they gave me, so 26 million psychiatric inpatient days in 2019. So that's a very low end, because that was only psychiatric hospitals. So it didn't include general hospital psych wards, didn't include emergency rooms, didn't include a whole bunch of stuff. So if we said approximately 50% of them are formally involuntary, and that's the lowish end based on my research, then we're conservatively, we've got a number of $19 billion a year that's of revenues being made off of civil mental health laws, incarcerated patients under those laws. And that's 5 times the value of the private prison industry. And of course, I've incorporated here both the public and private sector together into my number. So it's not a direct comparison, but it just gives you a sense of the scope of the issue and problem. And, I think the private prison industry and issues with that profiteering off of prison inmates is an issue that does hit the media a fair bit, that we're publicly talking about and there's concern about. But this is almost never on the radar of the general public, as what does it mean if so much money is being generated by incarcerated psychiatric patients. And so here's an example. So Tampa Bay Times did this terrific story. You're trapped, they're cashing in, how one Florida psychiatric hospital makes millions off patients who have no choice. I was immediately interested in, what's the scope of this issue? How far does it go? So I called up the Department of Justice, because I'd seen that they had done a number of cases in it. And I interviewed an attorney in the healthcare fraud division at the Department of Justice. And these are everything in bold or direct, his wording, not mine. So he described, like, this guy talked for 20 minutes before I asked a question. He was so passionate and concerned about these issues. And clearly he declined to really try to put a number on the scope of it, because of course, they have to just stick, but these are the ones we found. So he wouldn't speculate on how about all the ones you haven't found yet. But he does say a few things that are pretty important about that. So he's got a massive network of patient recruiters, or body brokers, he called them, rounding up vulnerable people from homeless encampments, long-term care and assisted living, group homes, using misrepresentations, coercions. Often they're giving kickbacks to administrators of these facilities and rounding them up in vans. Sometimes they're offering free mental health assistance. So there's been a number of articles about the people in that situation that just came in for the quote unquote free mental health assessment. And then they were quickly incarcerated against their will, and their insurance was billed as long as it could be. The patient victims are drugged so that they're docile and don't complain. And this is how he described it, which I just thought was so powerful. You need doctors and nurse practitioners and others who oftentimes are getting kickbacks and bribes. It's an assembly line of fraud. People are bought and sold like cattle, literally, to make these schemes work. And that's not hyperbole. Again, all of this coming from an attorney at the healthcare fraud division at the Department of Justice. So, this to me was really, I mean, I talked to some people that had been through this. There was a heyday of this back in the 80s and 90s. And there was real aggressive legislating and investigations by governments to stop this. And as a result, the number of private psychiatric hospitals in America dropped about 50% during that period. But the numbers of private psychiatric hospitals have now bounced back to the 1980s and 90s levels. And I'm thinking this is why. We don't really have the numbers to prove that, but it certainly could be. Here was another article that came out. It's interesting. It's great research from BuzzFeed, where they looked at UHS, Universal Health Services, which is the biggest psychiatric hospital chain in America, 200 hospitals. And they interviewed hundreds of people that had worked there, currently work there, or patients, current or former. And it was all about how UHS was involved in this kind of blatant fraud, holding people simply to bill their insurance. And you naturally, I think as any person would, you're kind of thinking, maybe this is exaggerated. Could it really be that bad? And then the Department of Justice did an investigation and indeed found that that was exactly what was going on. And they told me that essentially it's media articles like this that often twig them to investigate a place. And in this case, there were some whistleblowers from within the company. So this is just a shot of the Universal Health Services settlement with the Department of Justice from their website, where they talk about UHS hospitals forcibly detained people who did not require or no longer required hospitalization, while they improperly used physical and chemical restraints and seclusion to keep them there and bill their insurances. So $117 million settlement across just a small number of hospitals. And that's not done yet, because there are other hospitals that are still being investigated by the Department of Justice. And you can see that's 2020, so very recent. So I just like to talk a little bit about what I would call explicitly political uses of mental health law powers. I think all of this is very political, don't get me wrong, but just where it's really, really blatantly obvious. So this was against pregnant people that these laws are increasingly used, or sometimes they're actually writing whole new laws that are even more draconian than mental health laws against pregnant people. And, this was a quote from Lynn Paltrow, director of pregnancy justice. In many states, pregnancy has become the excuse for depriving pregnant people of any semblance of due process. The issue here is this treatment, but not punishment sort of slogan. They had that slogan. She said, yeah, we've stopped using it because we realized that as soon as we said that, a whole bunch of healthcare organizations of different kinds were kind of supporting it, saying, yeah, that's right. We should be forcibly treating these people, not locking them up and not criminalizing them and putting them in prison and stuff. And so she's, okay, yeah, that's a problem. So they've stopped using the treatment, not punishment slogan at that same level and trying to say, yeah, we're not really against coercive psychiatric treatment either. But it's interesting, if you go to their website, you'll see a lot of the endorsements from the American Psychiatric Association, Nurses Association. All these groups are often using this kind of language where they say, yeah, no woman should ever be locked up in a prison because she's pregnant and maybe substance using. She should be helped, and helped could be that we're going to lock her up in a psychiatric hospital and force her into withdrawal. Or in some cases, I saw people being transferred from a substance onto an addictive psychoactive drug that was a psychiatric chemical. So there's not really a lot of science to what they're doing or why they're doing it. It's very ideological. So another one was workplaces against whistleblowers. I did not realize the scope of this either, I have to say. This goes back to 1989. It's an incredible read. I quote it extensively in my book, but you can pull this out of the congressional hearings. I was surprised that they didn't really get much attention at the time, but there was this parade of people, mostly from the military, because it was before the House Armed Services Committee, talking about it. So here was Michael Tuffarello testifying at the Whistleblower Protection Act hearings. He'd reported organized fraud in the U.S. Navy payroll system. And he said, I was immediately forcibly hospitalized. My uniform was taken away, and I was issued blue striped pajamas and slippers decorated with happy faces. So as a result of those hearings, eventually, some years later, the United States Code 2302 was passed that prohibited this, so prohibited personnel practices. It's illegal to order psychiatric testing or examination as a form of retaliation against a whistleblowing employee, because there was just like a lineup of people talking about having had this experience who were ultimately vindicated in the sense that the whistleblowing had proved to be accurate and valid. Nevertheless, they had been psychiatrized. Tom Devine, the legal director of the Government Accountability Project. They represent many whistleblowers in America, from Edward Snowden to the guy who did the Pentagon Papers many years ago. And he said to me, it remains a bread and butter harassment tactic to force people into psychiatric evaluations and potentially incarcerate them, because it's a way of discrediting them. And here were some examples. And I use these examples here because you'll notice that they cross a number of different types of agencies. So it's sort of widely known, this tool, that it can be used. And here's the one that's on the horizon, becoming more, is against burgeoning climate activists. And there's some of the phrasing I've grabbed from, that's an American Psychological Association, Eco America. That's, David mentioned earlier, I do some neighborhood community development work. And so one of the things we're interested in is how can communities adapt to mitigate climate change. So I've been reading some of these documents where Eco America is a resilience policy think tank for community resilience. And they teamed up with the American Psychological Association to essentially define people's reactions to climate change as borderline mental disorders. And you'll see that article from Psychiatric Times by a psychiatrist saying those who have distressing or catastrophic thinking about climate change need treatment with psychotherapy and or medication. And I interviewed an interesting guy, again, through my other work. I met him, Galen Myers, and this is sort of some of the work he does. He's a co-founder, yoga meditation instructor, collaborative design counsel with the Transition Town United States organization and the Inner Resilience Network. And that's where I met him through this. And I was talking my book and he went, oh, interesting. Yeah, I've had that experience. And I said, oh, really? And so, yeah, he shared it with me for the book. And this was interesting because he actually ended up coerced into a very high-end facility. So he emphasized to me over and over again, he actually got a lot from the experience. That it was a substance use treatment facility mainly. He was in a group setting where a lot of the facilitators were actually peers, people who'd experienced substance use themselves. They shared a lot of personal stories with each other. He found their stories very powerful about their experiences of trauma in their past that had led to their use of substances. And so he really had a very, very positive experience overall, he said. Nevertheless, he also said this: when I told my story, it was constantly reinterpreted as there's something else going on. He's depressed, and that's why he thinks the world is collapsing. It made me mistrust my own perception of reality. It made me mistrust my own intellectual process, which was really damaging. It was traumatizing, trying to plead to be understood. So this was a person who was, as a young man, was very, very distressed about climate change and what was happening in the world. And he was getting psychiatrically labeled. And so even though in this very high-end environment, he was generally treated very well, the food was great, all of that kind of stuff, he was traumatized by it in this way, because his voice, his agency was so profoundly discredited. And I think that's very important, because that's something that happens to everybody who's forcibly treated. Your voice is ripped from you, your own credibility. They're trying to pull that from you so that you doubt yourself on this very, very profound level. So yeah, let's move on to the science about this. How are we doing for time? Pretty good. So I'm getting close to the end here. So what does the science say about forced treatment? There was a great question earlier that I asked the FDA as well. I asked them, hey, have you ever actually specifically tested forced treatment? Because already the lines are so blurry around placebo effect and what works and doesn't work for voluntary patients that actually really want these drugs. why don't you test it separately? Because of course they test a long-acting injection versus an oral medication because it's a different method of delivery. So I'm saying, well, gee, it seems like a different method of delivery if I'm voluntarily taking a pill in my mouth or you're forcibly stripping me and sticking a needle in me. Like, so why don't you test that? And they just, thought I was being ridiculous. So what does the science say? It's very little. There's very little study going on there. But use of seclusion, physical and chemical restraints are very common in psychiatric hospitalization, despite a remarkable lack of evidence to support their use. It's just very little studied is what's really going on in the literature. And these are all citations you can get from my book and from my online sources. Locked wards, constant monitoring, emergency meds are not supported by evidence and are difficult to justify. Psychiatric forced medication is a remarkably understudied practice. I ran into this a lot. And involuntary treatment is based on tradition rather than evidence. And it's important to note, most of these people were supporters of forced treatment. These are not the critics, especially this last guy. He's a real promoter of it. And they're just acknowledging that this is where we're at with the science. So, and this was a summary. Some people that were linked to the World Health Organization did a study. Coercive interventions in mental health care continue to be used extensively, although there's little evidence they confer any clinical benefits, and they're often associated with negative outcomes or highly distressing and even traumatic for people that experience them. Under the Convention on the Rights of Persons with Disabilities, psychiatric forced interventions are deemed arbitrary detention and torture. So we have to ask that question of why are they being used? If there's no evidence that they help, what do they do well that's not being studied? Well, Joanna Moncrief was talking about that, what they do well. They tranquilize really well. So improvements or alternatives, we could ban it. I'd probably go there, but I don't think realistically we're going to get there. So I talk about other things that we could do. And this is not something I go into extensively in the book because there's so many other writings about that are better, but housing first type approaches, more housing overall, enhancing community mutual aid. We really need better laws, better data gathering, some sort of strengthened oversight and accountability and tracking of outcomes. Hey, why are we tracking no outcomes? Like most hospitals in America, I can find out how well heart patients are doing when they leave a hospital, how many people were killed during the surgeries and things like that. But you can't find that for anything psychiatrically related. It's ridiculous that we're not tracking outcomes at all across the board, right? Let alone forced treatment outcomes. Be great if people could have psychiatric advance directives. If you did appreciate being forcibly treated, fine. You could write that up and say, yes, I want it again. Here's what I like. And if you don't, you could say, here's what I want. But unfortunately, they're often not respected. The World Health Organization has put out a whole bunch of guides for states to follow. You can find those online now. And of course, there's non-medical therapeutic options. So, there's tons of these. So why aren't they being implemented? And to me, the core issue comes back to that. The current legislative authority gives absolute final authority to physicians under mental health laws. So it needs to be demedicalized, that legislation, because there's just no reason for that. It doesn't make any sense. There's no evidence that this is truly a biological disease of some kind that medical doctors are uniquely trained to handle. So really, I would suggest, why not an interdisciplinary group of people that are in charge of actually whether somebody's going to be incarcerated or not. And doing that, we could also separate out forced treatment from forced detention. There's a lot of arguments why somebody might, you might want to constrain somebody's physical activity at a particular time, but do we need to get in there and start meddling with their brains with these drugs against their will? And my final priority actions, I would say, is we need more public education about this for sure, honesty and openness about actually going on, because we don't have that right now. And there's a desperate lack of political organizing and activism in this space. As a journalist, normally if I'm researching an issue, I can easily just search on the internet for who's pro-logging and who's against clear-cut logging. And I can easily find organizations that stake out either side and are willing to talk on the record about it. But if I start looking for organizations that are blatantly anti-forced treatment, it's very hard to find them. There aren't that many, even ones that are critical often aren't forefronting that issue, things like that. So I think both nationally, at state levels, local levels, you need people organizing together to speak out more and do some public education. So thank you. That's the talk. I just want to, I'll put up, I have lots of time for questions now. And I want to say, yeah, the books are, you're not going to get them anywhere cheaper than they're selling them for back there. So they're $20, but also you 30% off hardcover if you use the code RIGHTS at BenBella, and 50% off the audiobook right now. You can find a link to that on my website or any of my social media. So yeah, thank you very much.
Thank you, Rob. I actually don't have any questions submitted online yet. So David, if you have any questions in the room.
I'm scanning the room. I know we're gonna have questions. Catherine spoke with an open house at Advocates for Families at Work.
You're all invited, please come. She's on the I just do have a question. In your research, how many, you kind of did broad and there were a few chunks with children listed, but how often are children basically put into facilities against their will? Did you do different research for children versus adults?
We are asking what the actual numbers are, because we don't have great numbers, but anywhere I found them, it's gone up a lot. So for example, I think number is coming to my head right now because I was just looking at it, was in, California, it went from 7,000 to 21,000 recently. So 21,000 children. That's a lot, because that's the official number, and the official number for overall was about 150,000. So 1 in 5, were children. In Florida, again, I forget the actual number. The Baker Act Reporting Center can tell you that, but it's gone up. Oh yeah, dude, that was a very potent number. So 1 in 100 children in Florida are psychiatrically incarcerated in a year. That was the number I recall coming up with when I looked at those numbers, which is a shockingly high number. So yeah, it's common and becoming increasingly so, because there's this belief, right, that it's better for us, right? There's this notion that, oh, the reason we have this mental health crisis out there is because we haven't been forcibly treating enough people aggressively enough. That's the narrative that's out there. And so we're saying, okay, we got to get to the children even younger.
Rob, I'm curious about the lawsuits and the liability, and you mentioned the major one there with the Department of Justice over $100 million lawsuit. It made me think of the lawsuits that have been won against the pharmaceutical companies for some of the issues around medication, some pretty big lawsuits. And I'm a little afraid that, I don't know how much this might carry over into other arenas, but with the pharmaceutical industry, it seems to me that from a lot of the things I've read, it's almost like it's built in as the cost of doing business. When you look at the scope of how much revenue, then these damages sound big, but they're very small in the big picture. And I don't think they're enough to really affect the change that needs to happen. Your comments about that?
Oh yeah. And I use that example in my book from UHS, where shortly after that settlement came out, the $117 million against Universal Health Services, their stock skyrocketed, because it was like all the investors like, woohoo, because they knew that these investigations were ongoing and they were a little scared about how much it was going to be, but they immediately made the money back. And there was an expert quoted in a healthcare magazine that was reporting on it. An expert was saying, oh yeah, we see that a lot in these kinds of cases, that healthcare companies will make more than the money back, more than the penalty back immediately in the stock market when the settlements come out. So yeah, it's definitely not enough. I think there needs to be more like a criminal approach to how corporations are doing this.
Okay.
Do you see any positive outcomes from psychiatric treatments, 911 or 988?
See any positive outcomes? Well, I mean, sure. Lots of people say they love, calling a helpline and being able to talk with somebody. Like you see that there's evidence that bears that out scientifically, and lots of anecdotes, right? People like calling these lines and they get something beneficial from it, but they really don't like, having their call traced against their will. I haven't seen anybody reporting a beneficial outcome from that to me, but I'm not sure if that's answering the question exactly, or it's coming from somebody online. Yeah.
Actually, they're saying the chat function's not working, the folks are having trouble asking questions, I guess.
Yes, they need a, on the bottom of the Zoom screen, there's a Q&A section, and those will come directly to me. if I type it in.
So yeah, I mean, but definitely, like I think I talked about earlier, there is this notion of nominal involuntary. Like definitely the people, I talked with people who are like, kept in a hospital for a long time and sort of gently pressured to take medications, and then finally did and went, hey, you know what? Yeah, I like this, and they stayed on it for the rest of their lives voluntarily. So I heard stories like that, but rarely did I hear anyone saying, yeah, I was like forcibly stripped and I was, been heavily medicated against my will and for a prolonged period and now it's great. It's not that I will say I've never heard it, but even that story is often disturbing because you don't know what's happened. As Sarah David at Wildflower Allowance said to me, you often don't know, has the person just been beaten down to that level too, right? Where they're going, okay, I guess I could never have lived a better life. I guess I had no hope of having a different experience. So this is the best I could have ever hoped for. So you don't really know. And I think that's fair enough, right? If somebody wants to say, well, I'm somebody, so obviously I respect that if I hear that point of view, but I still have that critical question. And I think that's where we need to track these outcomes better and allow people more freedom to really say what they're feeling. Because even those people often say, yeah, but I'm still traumatized by the fact that it happened or that they did this or that to me, even though now I'm glad that I take the medications. So.
Maybe I noticed several questions came in. Ashley, do you have enough time to maybe formulate one or two questions from the Q&A?
Sure, right here. Rob, could you please discuss forced ECT?
What's that? What's the question?
Could you please discuss forced ECT?
Yeah, well, that, my own dad went through it. That's the introductory chapter of the book. And one of the things that sparked me to research all this issue. And, I think it's still, it shows you where we're at, that if you mention this in the broader public, often people think that what we still do, electroshock. I can't even believe it. And then you have these doctors saying things like, oh, it's totally different from the 1950s, but it's not different at all. In fact, they were using anesthetics, they were using all these same techniques back in the 1950s that they are today. And the fact the shocks seem to be stronger overall because we're giving more powerful drugs to paralyze the body so that the body doesn't go through such severe convulsions that bones rupture. So we're giving higher levels of drugs which create resistance in the brain, and so they have to increase the intensity of the shocks. And yeah, I mean, it's just brutal what people are put through. The notion that this can be done against people's will is, to me, just really horrible. I don't know what else I can say. I have Sarah Price Hancock's story in my book. Here's somebody who suffered severe, almost total amnesia from 116 shocks, most of which were against her will. And is not recovering that, and is struggling with a whole bunch of sort of other associated brain damage related experiences of seizures and difficulties breathing and all sorts of things, which are common electrical injury side effects. And it's just brutal what people like that have had to go through. Now that's a more extreme case, we hope, but again, we don't even have the data. So I hope and pray that people like Sarah are rarer rather than more common. My dad didn't experience that extent, but he only had 21 shocks. But we don't know. We're not tracking that. Texas right now, as far as I know, is the only place that even gives you the numbers of people that are being subjected to that. So we really need to get a better handle on it.
We got Lori.
I just want to say thank you so much for bringing light to this, and my question is, are you afraid of the blowback from you opening this can of worms up?
Well, I've been saying lately, like, I've never been forcibly treated, but I kind of think of myself as a peer. I think of myself as in some ways we're all under the shadow of forced psychiatry right now, because I do really believe, like, for me, it's not hyperbole to say I think it can happen to virtually anybody. And so, yeah, I do operate regularly with the thought that, oh yeah, somebody could easily call 911 on me. I report on instances like that. Just some YouTuber guy is, doing a live stream and somebody calls in a 911 call on him during the live stream. So lucky he had the evidence of what he was actually doing as compared to what the 911 caller had reported to police, but he gets taken down by police right in the middle of the live stream, right? Like, so that kind of stuff can happen very easily. So of course, yeah, I have real concern about it. I've written up my advance directive, even though they're illegal in the jurisdiction where I live right now, for you to have a psychiatric advance directive, which is such a blatant prejudice against psychiatric patients that those kinds of laws exist. But I've written it up anyway, determined to take it to the Supreme Court if if somebody pulls that on me and I have to get forcibly medicated. I'll fight it all the way. But anyway, yeah, so I do. I mean, I don't operate on a daily basis, obviously, with a great fear of it, but I do think everybody should be concerned.
Another one in the room.
Do we know about if there is any role of medical or social research going on in the context of implementing these involuntary treatments? Obviously, there's the profit portion and the financial portion that you touched on, but sometimes we know with medications, the way they are dosed and implemented is part of a broader research. Sometimes with the pharmaceuticals holding the purse strings, are there, and not to point the finger at universities, but for example, institutions, large ones interested in this kind of research that may be tied to it? I just don't know if you can cross any of that.
Yeah, only recently. So I don't think it's in my book, but yeah, it's something I really want to look more into. So I found a case. So pharmaceutical companies heavily supporting get people out of prisons, get the mentally ill out of prisons, that whole narrative, right? And it turns out they're funding a bunch of these neighborhood community development initiatives that I work, and that's kind of how I came across it a bit. It's like, oh, well, what's that all about? Oh, the same pharmaceutical company is producing Maintaina, the Abilify injectable, long acting. And so at the same time, so this was their philanthropic arms doing that, their research arm of the pharmaceutical company has contracted with a bunch of health authorities, health departments, universities, so on, and they're paying, I don't know how much yet, but they're clearly paying doctors and everyone to be involved in the study, which is just switching people on to this long-acting injecting and trying to show that, they can survive better in the community on this drug. And actually, it looks like one of the results just got produced recently. Somebody forwarded it to me. And really, it was just not even that. It was just, hey, guess what? You can do this twice a month or once a month now. And, they got some new adjustment to the way the dose works. And that's all they've really proven from this study, right? So really, it was just a way of getting, it looked to me like it was just a way of getting a whole bunch of new people on this particular drug and paying a whole bunch of doctors to help them do it along the way.
You can sort of 12 weeks or you can get injected with this thing.
Yeah. So this is going on. I don't know the extent of it. I think if it's going on though, like this was a multi-city trial, 5 cities, lots of people, lots of doctors, lots of health departments. So I'm thinking it's probably not the only one. And it's very dubious because these were all involuntary patients. Now, technically, you're not supposed to have an involuntary patient in a clinical trial either, right? Well, where's that hazy gray area? They said, oh, we worked independently of their involuntary status. We interviewed them, till you get all the details, you don't know what's going on there.
Ashley?
First, several of the attendees asked me to say thank you to you, Rob. And then someone asked, who is using non-coercive approaches that are promising using public funds?
Who's using non-coercive approaches using public funds? Well, I mean, I don't know how to answer that exactly, because of course, the entire mental health system throughout it, right, there are people that are trying to work in non-coercive ways, of course, that are using public funds. So, out of deference and respect to them, I don't want to deny the existence of the non-coercive parts of the mental health system, or even just the individuals who are non-coercive in their approach. And definitely it can vary a lot from individual to individual. But currently, in terms of a sort of systemic testing of a non-coercive approach, in the sense of, let's take people that we would otherwise involuntarily treat and not coerce them and try some other method. I'm not aware of any that are going on right now, other than individual organizations and groups that are trying to create diversion strategies of some kind. People trying to create an emergency respite place. Wildflower Alliance runs one of those out of Massachusetts. I know other individuals that are trying to get them going, organizations, just an emergency respite that's run by peers that would be non-coercive, a place for somebody to go instead of to a psychiatric hospital to avoid that coercion. So that kind of stuff's going on, but nothing at a mass systemic scale that I really know of.
Okay. Another question. Are you concerned that your message scares people to not seek care when they're in crisis?
Oh, sorry, I missed that question.
Are you concerned that your message scares people to not seek care when they're in crisis?
Oh, yeah. I mean, that's what I'm told routinely. Ever since I started working on involuntary treatment, it's clear that the system doesn't want it talked about publicly because they know it would scare people, the truth of it all. And so, yeah, I've met resistance all the way along. You shouldn't be doing this. This is irresponsible. This is dangerous, what you're doing, and all that. And I'm of the mindset that people have a right to know, and most people would want to know. I think even the person usually who's saying that is often a person who would want to know themselves, and they already know. And they're just saying, oh, don't tell these other people because we have a paternalistic attitude about them. They shouldn't have rights. They shouldn't have this knowledge. I should, but you shouldn't, right? And yeah, I just don't agree with that at all. I think I would want to know. I think everyone I've talked to would want to know.
Really quick, what your thoughts are. There's an increased dialogue, integration of the anasarcosia, INAMI, and I know people have, but it's being integrated pretty wide stream. And it's interesting about how that gentleman went into the treatment center, he questioned himself. So my question is, especially with community force treatment, how broad do you think they'll be able to stretch that terminology?
Oh, yeah, it's already infinitely broad. That's the problem with it. So my problem with that term is, one, it's just very insulting and demeaning to someone's basic humanity. It's fine if I say it about myself, because, yeah, maybe there was a circumstance where I realize now in retrospect, I wasn't making good decisions, and, and I appreciated having some support or help in making those decisions. Okay, fine. But the way this thing is being used is it's being applied to other people. And the way it actually plays out is it's sometimes literally written into legislation this way, and it definitely plays out this way in hearings all the time, is it's just, do you agree with the psychiatrist? That's it. There's no broad test to figure out how insightful someone is or isn't about whether or not they're in distress. In my experience, most people know when they're having some level of distress and upset. It's not like they don't know where their legs are, or things like, I don't even know what people mean when they use the term. Ultimately, I think it's just kind of thrown out there like just a sort of generalized prejudice. But definitely what we see, and it's written into laws, I talk about this, is a whole chapter in my book called The Catch-22 of Insight, because what actually plays out in practice is if you show insight, all the worse for you, because what you're doing is you're admitting now, oh yeah, I am mentally ill. Yeah, I do need treatment. You're basically confessing to your need to be locked up. So it's a no-win situation. And if you conversely say, I'm not mentally ill and I don't need treatment, well, now you're lacking insight. So when I show cases of that, like in people's medical records, where literally they were saying, yes, I've been struggling all my life. This is what I do. I appreciate this medication. I don't want this one. This is how I handle it. I think I'm fine. I think I'm ready to go. And that was all lack of insight, right? She doesn't realize she needs to be in the hospital. She doesn't realize her current treatment are not helping her enough, and there could be better ones, all of this kind of stuff. And they went to court to try to hold her longer with that argument. In this case, she won. The judge agreed with her that she was showing sufficient insight. But yeah, I think it's just a toxic contribution to the public dialogue, and we got to get rid of it somehow. It's this terrible abuse of people to even say they lack insight. What does it even mean?
Trish.
Yeah, I was, not, one here. Oh, not to toot our own horn here, but maybe two. But we run the pathways of peer support, and we're not coercive, and we've had some, all my years in psychiatric care, and we're talking since I was 10. And I was at Caparello State Hospital at USC Medical Center, and a lot of cases along the way. This program has been the first program I've ever seen where people make their own decisions about what they want to do, how they're encouraged to meet those decisions and to move on if they can. And if they can't, they're welcome to stay. But they're supported. I just can't say enough good things about it. I have seen through this program people really engage and grow. But I'm not seeing a huge amount of support.
Yeah, but you're getting, you're getting some support here, so that's great, you know, and there needs to be more facilities like that, just places for people to come in a day, like you're doing there.
Pathways is one of the most best kept secrets in that.
Yeah, I mean, it's huge. Everybody I talked to just talked about problem solving as being one of the best approaches for preventing people from getting hospitalized. Just often it is episodic, what people are going through in some way. And so if they have someone they trust that they can talk to, a place they can go where they can hang out for a while, and just there's a wider latitude of an acceptance of unusual behavior or unusual feelings. And this can be huge in people's lives. So yeah.
And respect. And people are asked what they want to do with their lives. And then we help them manage that. We don't tell people what they have to do.
Yeah.
To fit into our world. We help them fit into their world, their way.
Mm-hmm. Yeah, and I think peer stuff is great too, because often it really is an immediate connection. If you can say to me, hey, I've been through something very similar to what you've been through before. There's a sense of like, I don't feel as judged suddenly. And then, you know, I let my guard down and I can have a more honest conversation. I can feel that sense of connection. And it's amazing, you know, and I want to say that to everybody that works in the system in some way. Like I do hear this all the time from these people is often there's just one person that they meet. It might be the lawyer who represents them. It might be one of the social worker that just gives them more latitude and stuff, like just who understands them, who makes that connection with them. This has been huge for people, and they'll often say that was revolutionary because it could sometimes open the doorway for them to realize themselves, oh, I just went from like, I'm freaking out in a panic attack, I need to get locked up, to, oh, okay, I got over that, you know, and all I really needed was someone to kind of talk to or someone to support me for a while. So if you're somebody who's like that, and I'm guessing a lot of you who are here for that reason, you have a bit of that in you already, then I encourage it and support it. That definitely lots of people reported to me it was life-changing to just meet somebody in the system somewhere who said, yeah, I understand you and it's okay, and no, I'm not going to just call 911 on the drop of a hat.
Maybe one or two more.
I briefly talked about the LGBTQ population. Have you found any research on churches who are using this sort of programming to like pray the gay away and all those deconstruction camps that they're working on getting rid of?
So I'm not sure exactly what your question is, but what I will say about what I know about churches is unfortunately, they've heavily bought into the medical model across the board. And then often they come with their established prejudices against certain populations. But by and large, what we're seeing is massive institutional buy-in to the medical model and forced treatment. And so they're often, because they're maybe working and doing charity work with a population that's struggling in some way, they've become a major conduit into the mental health system. I think that's really unfortunate. It would be great if somebody could reach out to all of these church institutions and sort of uneducate them from what they've been educated into.
Yeah, I just want to comment about how many mutually benefiting forces there are. I work in community health, and I think often, and maybe my colleagues who work with me would say, we see, especially it's coming up from the younger generations, not so much, I don't want to be in the mental health system, but I want to have diagnosis. I want to be on medication. It's, and in fact, many people that come for services will come in with already the list of pills that they would like to be on. And young people, junior high, early high school, having, some kind of psychotic disorder or a dissociative disorder that they can talk about, so reinforcing for them. And so you've got the pharmaceutical industry, you've got the hospitals, these for-profit, all these private hospitals are popping up across the state. And it's just the money-making forces combined with the marketing that they do, and they're willing to accomplish all those in our people who want. It's just, it does seem like there's this tide, and I don't know what we can do. I mean, we push back and say, why don't you try jogging or get a job? These are some things that can help you. But it's hard because we see just this desire to have a diagnosis and to be in treatment, get on medications, and yeah, I don't know. It's a challenge all the way around.
Yeah, no, exactly. And the embracing of mental health ideas has become so widespread. We've never had more people taking psychiatric medications than we have now, 20% of the population at any given time. So that's what we're dealing with in terms of voluntary care. And yet somehow forced care is increasing at the same time. So this is definitely an industry that's moving in a certain political direction very strongly and turning back that tide. I'm just focusing on this piece of that puzzle because I find tackling, mental health has come to mean all things to all people. It's hard to even have a discussion of what do you even mean by mental health, right? It's it sounds like sports could solve that. You know what I mean? Depending what we're talking about. So now I'm just really focused on the force issue because I'm like, people should at least have choice. Let's start there. And then, I really respect all the research that's going on to kind of talk about the dangers of these medications, but I'm trying to avoid it because then I'm up against a tide that's massive, right? It's more than half the population probably right now that's fully embraced mental health ideas.
Maybe one more.
But just a quick note on that question. Our 10-year-old nephew has brought home that vocabulary of the mental health system. Just playing a board game, you might say, "Oh, I'm so depressed. Look what happened." So where did you get that? We never said anything like that when we were kids. But sorry. Go ahead.
No. Well, but if you've got a question coming up.
My question is on the more human rights legal aspect, because I know that the World Health Organization, as well as the United Nations Commission for Human Rights, have been very critical of the U.S. as far as forced treatment and violations of human rights that go along with it. And is there any kind of organization, I don't know, that may be put in to challenge this whole system of forced treatment on a human rights basis in the U.S.?
Yeah, well, I interviewed Tina Minkowitz in my book, who's been one of the leaders in that area. She's one of the main people that, as a trained lawyer, as well as a psychiatric survivor, she was one of the main people that influenced the United Nations during the CRPD process. to take on these positions and to make a legal rationale that made sense to them to mesh with what the science was showing. So she's a great leader, and she's worked off and on with the what do they call the CRUSP, CHRUSP. It's listed in my book. I forget what it stands for. Users and survivors of psychiatry, something like that. So she's worked off and on with them, which are part of the International Disability IDHA. I forget what they stand for. This is all in my book. But anyway, so they provided some leadership in that area, but no, clearly it could be more prominent, more well organized, and all that. Interestingly, Tina said to me she thought some of the political resistance in America to the CRPD was actually maybe not even around the psychiatric issues, but around children's rights. She felt that there was a strong family movement here that would say, no, you can't give children or women these kinds of rights that the CRPD would also give them. So yeah, I don't know, but that she thinks that's preventing political activism around the CRPD here. What's interesting, though, is we see the disability community now more readily embracing psychiatric patients' rights. Like even just 10 years ago, I did not find that. If I called a disability rights organization, they were like, hey, those people should be forcibly treated. It has radically changed. And I attribute that almost entirely to the CRPD and influence of that, and to credit Tina Minkowitz for that incredible amount of work she did.
All right, Ashley, any more before we end?
There is one last question if we have time for that.
Quick one.
Okay. As a clinician, I've felt that involuntary admission was in the best interest of the person, and have had that same person later return to me and thank me for forcing what they would not have done voluntarily. Of course, involuntary treatment can have negative outcomes, but should your message also reflect that there are positive outcomes to fairly report both sides?
So you might, obviously a lot of mental health practitioners tell me this, hey man, my patients love it. And, I quote someone saying that in my book, and I just go, okay, well, show me the data. Because often it's just an anecdotal story like that. Oh, I can tell you. And I'm like, okay, yeah, can I talk to the person? I've had people saying that from the beginning of my career, 25 years ago, writing about this stuff. Oh, you misrepresent. There's so many people who are happy. I'm like, okay, where are they? Because I can't find them. They're not speaking out. Can you send some to me who will talk to me anonymously, not anonymously, however? They don't really show up very often at all. But I'm not going to say never. I'm just going, okay, let's get the data. If you as a practitioner are confident that you're doing something good, then you should be the one lobbying for data, not me. Right? You should be saying, yeah, I want to prove Rob Wipond wrong. I want to go out there and we're going to start in our institution and in our community regular tracking of people who go through involuntary treatment, what their outcomes are, how they feel about it after the fact. And we're going to make sure that they feel supported and safe in reporting what they honestly feel. We're going to have independent people then do that follow-up research in collaboration with us, where we're identifying, the whole process. That would be great. I think it would benefit us all to have that kind of data and more of it everywhere. So that, that's all I can say. I don't focus on that in my book, because I think those people get lots of voice already. They're already reported on already. Every time I hear involuntary treatment discussed in the news media, there's almost always somebody, suggesting that it's really good for people. So I just wanted to give voice to a lot of people who say, this wasn't good for me. And it seems to be built into the idea of force as opposed to just nominally involuntary.
All right, that was kind of a mic drop spot. Anyway, very good substance. Let's thank Rob one more time, please.
Thank you. Thank you.